Good evening. My name is Kent Dix and I'm CEO of Life365. Welcome to our fourth in a series of webinars related to COVID-19, telehealth, and remote patient monitoring. Before I introduce our panelists for this evening, I want to take a minute and thank all of the healthcare providers, first responders, family caregivers, home healthcare workers, child care providers, food and grocery delivery, transportation, healthcare manufacturers, and many others. Thank you all for your service. I also want to let you know that everyone will be on mute and that we will accept questions via chat and try to entertain a few questions throughout the webinar. We have reserved some time for questions at the end. If you don't get to your question, we don't get to your questions, we'll answer them after the webinar and post the recorded video to life365.health website tomorrow. Now I want to take a minute and introduce our distinguished panelists. First, Dr. Sage Breslin is a breakthrough and transformation coach, a trauma psychologist, and a motivational speaker, a screenwriter and best-selling author. Her first book, Lovers and Survivors, as well as her work with Chicken Soup for the Soul, LLC, have generated worldwide acclaim. Her second and third books, The Secret to Conception and The Secret to Conception Workbook, have enabled hundreds to resolve fertility challenges. Her fourth book, Daily Pearls, 365 Days of Sage Wisdom, blends Dr. Breslin's musings with motivational quotes from a wide array of contributors and delivers an unforgettable and moving read. Her narrative storytelling style enables readers to experience life as she has lived it and delivers the inspirational message to so imperative for post-traumatic growth. While her colorful life has imbued her with perspective and insight, Dr. Breslin acknowledges that true wisdom is gained through collective conscious community. Her most recent book takes an even deeper dive into enabling conscious leaders to break through cognitive, emotional, and energetic barriers to achieve authentic, empowered leadership. The importance of this form of transformational work is evident, breaking through the conscious leaders and an entrepreneur's guide to amplify intuitive clarity, vision, motivation, and productive hit bestseller status within 24 hours. Welcome, Dr. Breslin.
Thank you so much.
Yeah, and sorry I butchered your bio, but we'll get better at it. Patricia Daiker is a registered nurse, board certified nurse coach specializing in diabetes burnout, and author of the online e-course Better Diabetes Life. She has been an RN for 35 years, practicing bedside at Baylor University Medical Center in Dallas for 15 years, primarily in the emergency department, and credentialed as a certified emergency nurse. It was during this time she developed type 1 diabetes, likely related to a viral illness from a patient. She has been has over 17 years as an executive in healthcare IT and is board certified in informatics nursing. She's currently is the CEO and founder of Dragonfly Lights, a company whose mission is to deliver support and services to people with diabetes and other chronic illnesses who are experiencing the psychosocial burden we know as burnout. She is a JDRF Type 1 Nation speaker, children's book author, and most recently, COVID-19 pandemic homeschool teacher. Welcome, Patricia.
Thank you. Thanks for having me here.
Yeah, not a problem. Lindsay Crawl is the founder and CEO of Enable Your Care, Patient Advocacy and Care Coordination. Enable Your Care is a patient advocacy service focused on educating patients on their options when engaging in medical care and decision-making. Prior to Enable Your Care, Lindsay served as Director of Provider Services on a $12 million grant from CMS tasked with building the state's first health information exchange. Most recently, Lindsay served as Vice President of Provider Services for the largest Southern Arizona home health hospice provider. Lindsay has a beautiful daughter attending college at NAU and resides in Scottsdale, Arizona. Well, welcome, Lindsay. And hopefully your daughter's listening, right, as well.
Yeah.
So I talked a little bit this afternoon about, I give stats, about the COVID, infection or pandemic that we're going through. And I usually open this up and talk about the number of people that we have that are affected by COVID. Interesting enough, I did the stats recently, and there's 2 million people in the world that have been diagnosed with the coronavirus or COVID-19. Last Wednesday, it was 1.5 million. So the week before when we did it, it doubled. This week, it actually looks like it increased by 30%. With almost 134,000 deaths worldwide, last Wednesday it was 88,000. The US is over 641,000 diagnosed, growing at 30%. With almost 28,000 deaths last Wednesday, it was almost 14,000 deaths in the US. So that's doubled, right, in a week. The numbers seem to be flattening out. Our healthcare resources continue to be very strained. My question on this, has social distancing worked? Are we at the apex? How can we use teleservices to not only take the strain off of our current healthcare system, but also provide behavioral health resources to those that need it? Just an observation, when I'm watching TV at night, I'm now starting to see a lot of behavioral health apps that are starting to pop up, say you connect to somebody, to be able to talk through your issues that are out there, which seems very relevant to do. Dr. Breslin, let's start with you really quickly, and welcome to the webinar. What are you observing in the marketplace today, or in the world today, or in the US today, around people coping with COVID-19?
Well, I think that, there's nothing static about this phenomenon. So I think that initially in the first week of sheltering in, I think I had the same conversation over and over and over again by Zoom as people began to deal with the shock of the phenomenon and deal with themselves at home and deal with business closures and just the unknown, the uncertainty was really just, the topic of the hour. I think now that we're in, by 5 weeks, I think there are different kinds of issues coming up. I think that people are and now have a level of, for healthcare workers, burnout, real, what I refer to as COVID fatigue. The acute stress disorder has sort of become entrenched. And then I think that there are other people that are becoming bored with everything. They want to just go into denial and say, okay, let's get back to work, or let's be able to get back on airplanes, because it's difficult to adjust to a new way of living. And then I think there's a big portion in between where we've adapted as much as we can, and we've tried to become compliant with invitations to keep ourselves safer and keep others safer. And we've identified the things that get in our way and that are obstacles and, challenges. But we're eagerly looking for solutions. So I'm seeing, a developmental kind of impact through as we move through this. And I do believe it's a through. I don't believe that this is going to be the way of our world forever. But I also see that it definitely depends on who you are and what you're doing and what has happened to you as a result of this pandemic. And that's going to determine how many resources you're looking for, what kind of services you're looking for, and how you engage in all of that.
Right. Great answer. So Patricia, I wanted to address something with you. You're an RN from this. How do we deal with, healthcare provider burnout, right, in all this? Because if we're just at the start of this within, 4 or 5 weeks, and maybe it's been going longer than that, we just didn't know. And some reports are saying, and I don't want to freak people out, but I'm hearing today that it's going to come back stronger in the fall potentially, and that we could be dealing with this till 2022, right, as well, in a new normal, in a new way of isolating ourselves. How do we protect the frontline workers and the healthcare workers?
Well, let me just start out first by giving a big shout out to all those folks. So I know I have a lot of family and friends, and I spent my time in the emergency department, so I certainly am connected to those people who are out there doing it. I think a lot of these folks are used to seeing hard stuff, but the hardest part is their world has changed, right? And so we all have to adapt to change, and it's typically difficult because this is moving very fast. I think as guidelines come out, as we understand the illness better, as we understand treatment modalities, the infection rate, all that stuff, their roles will change, the facilities will change, how we access healthcare will change, to the point of this telehealth. But I think a lot of the those at the front lines, they're going to need a lot of support. I see hospitals are providing that. We see the community reaching out to give them encouragement and support, and it ripples into their families. People are really afraid to bring the stuff home to their families. So far, they have decontamination units right in their garage where they come in and remove everything and figure out how to wash it. I think.
Is everybody frozen or just Patricia?
Just Patricia.
Okay, that's okay. So let's go back over to you, Doctor. Are you back, Patricia? Oh, sorry about that. Okay. Are you back with us?
I think I have an unstable connection. Can you hear me, Kent?
I can, yeah, right.
Okay, sorry, I feel like I went away for a minute. I'm not sure if I lost the connection.
You did.
But,
That's okay.
okay.
And so how do we protect the emergency room, crew, the healthcare crew, especially when they're going back to families? I mean, I've seen a lot of heart-wrenching, interviews on TV around, they're personally working long hours, but then they also believe that they're putting their family at risk as well. But they still go back, right to do that. Yes.
So I think that speaks to the nature of the calling, if you will, to be a professional that works in those areas. And I think there's, like with any disaster, even with 9/11, there's a short term and a long term. And so short term, people just do what they can to get by. They're trying to get rest. They're trying to get resources from the community. I know a lot of places, since elective services and treatments are not being done, they're pulling nurses and staff from other parts to help cross train. So it is chaotic, and I don't think there's any way around the chaos right now. But I trust that people will figure this out. The people that are doing the frontline work will come up with what's the better way to build a mousetrap, because in my experience, healthcare providers are innovators and they figure it out, right? Because especially in the emergency department, you never get to say, no, you can't come in. You always have to absorb and react. So I think those people that are doing that are going to do what they do best, and it's going to evolve over time. And I think in the short term chaos crazy right now, that's where we're at. I think there's going to be a longer term ripple effect, much like we saw with providers from 9/11. This is going to have lasting impact, and I don't know that we can protect or prevent all of that, because nobody can be prepared for something like this. We never saw it coming. So it's a change that happens. And I think when I look at all of this, just from healthcare workers to people living at home, anyone, we have had a huge change. And change can happen in two ways. It could be a good thing, you win the lottery, or it could be a bad thing and your life is upset. You could have financial issues, personal issues. There's all this change. And with change comes a loss. And overarchingly, that's what I'm seeing the world experience, as a loss of what we knew as normal. And we're all trying to figure out what's new. And when there's loss, there's grief. And I actually see people kind of going through a grief response, where there's this denial. No, this isn't happening. We certainly saw that, right? We saw anger, where people are trying to find blame and who's at fault. And we're going through that. We kind of get into this place now where we're doing some bargaining. So I'll try this, I'll try that. We're trying to figure it all out. I think we're definitely in a place of sadness now, where people are burnt out, they're tired, they're frustrated, they're ready for this to be done. So we need to get everybody to process through all those things. And I think one of the best things we could offer right now is to notice what's actually happening. Because if you have heavy emotions and you don't know why you're having them, that's really scary. But if you can say, I'm angry because I lost this faction of my life, my job, my finances, my stability, then that anger is meaningful, right? It feels better. So on a broad scale, we just have to acknowledge that we can't fix it all, but we have to work through it all.
So, that's great. So, Dr. Breslin, how can people, cope use some coping skills to try to, get through a lot of this as well? I mean, it's interesting. People go through and say, I think, Patricia, you and I talked for a few minutes today, and I'm like, if I was at work, I would probably be getting up every 30 minutes and walking down the hallway and, getting a glass of water or going to lunch with somebody and have a mental break. But I'm not doing that at home. I'm walking less, right? From that, I'm probably working more, right? From that as well. We should be exercising, we should be eating better, we should be sleeping more, but it's just not lending itself to that. So coping, how do we cope with this?
Yeah, I'm going to say again, it sort of depends on how this is being served up for you. So for instance, if you are really experiencing, acute stress disorder, this sort of form of COVID fatigue, you're going to want to do things that help you feel a sense of control, a sense of order and structure. And it won't be the same order or structure that you had before, because that doesn't exist probably. So anything from, organizing your sock drawer to, I saw a woman, I was walking the dog the other day, and I saw a woman vacuuming the area behind her water heater in her garage. Yeah. And I thought, all right, good on you. You're doing what is allowing you to feel like you can gain some control over this chaos, over this entirely new phenomena that you can't name it. You don't know what it is. You don't know the way around it. You don't have any sense of how long it's going to be here. So I would say that for people who are feeling more overwhelmed, doing things that create structure, that create order, even cooking, especially if you can cook by recipe, strangely can give you a sense that you are going from A to B to C to D to productive. I do think we have to be more gentle with ourselves than people are perhaps indicating. I know that in the beginning, people were saying, oh my gosh, we're going to come through this. Everybody's going to be in the best shape of their lives. We're going to have, our homes are going to be organized. Our gardening's all going to be done. We will have finished those 14 books that we were, put on our Kindle and so on and so forth.
A lot of babies, right?
A lot of babies for those who are being more productive elsewhere.
Yeah.
But I think we also have to understand that when we turn upside down and we are struggling to go right side up, it has an interesting impact. It's very unsettling. And the flip side of that hyper-productive piece of acute stress is the sort of depressed portion, which is having a hard time getting out of bed. Sleep cycle and circadians just crazy. Finding yourself binge watching Netflix until 2, 3 in the morning and then struggling to get up by 9 or 10. Or, if you're my 3 teenage boys, 12, 1, whatever it is. And because there isn't that same structure or demand, you don't fight it, you don't resist it, you just sort of go with it. And so I think
Sorry, Dr. Breslin, if I could just cut in there, you have great recommendations, but for me and my patients, they've already been chronically ill. A lot of them are going through chemotherapy. A lot of them are already homebound, struggle getting around the house. And so for our patient population, they've gone through a level of depression to a whole new level. Do you have any recommendations for my patient population that is not very mobile? Their norm was going to the doctor on a regular basis. They were seeing people at their pharmacy. What recommendations do you have for those folks?
Great question.
I think that finding some of the resources that are now available online, even if just learning to use your own phone or device or computer so that you can connect with a larger community. And I don't mean just watching the news. There are now many resources for those of us who are offering Zoom groups, Zoom rooms, so that they can do meditation together, so that they can have a place to even have social commentary, so that they can receive some guidance about how to identify and express their feelings. I know that one of the groups I belong to is, I volunteer for them, and I offer a 90-minute session per week where people can come and jump on and learn how to express and release and just identify what's going on with them. As Patricia was saying earlier, that sometimes when you are able to normalize and hear, oh my gosh, that's happening to me. Is that what we're talking about? Oh, okay. So I'm not crazy, or okay, this other person knows what that feels like as well. So I would definitely hope that a lot of resources are being promoted both online. I know I actually received something from one of my healthcare agencies today identifying a new resource that was going to be put in motion. So that would be my recommendation.
And I appreciate that very much. Thank you. And it has been just it's been a very new norm for all of our staff and for them as well. And I think one of the things as a healthcare provider that I'm struggling with is the tough questions of, if I'm that chronically ill and terminally ill, what have you, is this what my last is going to look like? Do you know? And it's like, that's difficult to be answering. And so to your point, all of our patients have started on community support groups. They're doing Zoom meetings, like-minded illnesses and what have you. But I just think the psychological damage that's being done of being not connected with their family, not being able to touch somebody through such a crisis is weighing on their psyche. I mean, one of our patients said the other day, I'd give anything for a hug.
Yeah.
And, and so that just, that gets to you. But I appreciate your insight on that. And I'm definitely going to look into more of the meditative pieces for my patients.
So can I switch over to Patricia really quickly, and then Lindsay, I want to bounce back over to you. How does a care provider, a healthcare provider, deal with making choices of who, these are really tough questions to ask, but who gets a ventilator and who doesn't get a ventilator? Who stays on a ventilator? It's going to be on there that has no chance of potentially coming off. Who makes those choices, right, from this? And doesn't that weigh heavy on the healthcare provider?
Yeah. So luckily, those decisions are never made in a vacuum. Every hospital has an ethics committee. And so that's usually a group decision. It's not usually a single person making the call. That being said, we're in extenuating circumstances. So whoever the attending physician is, or who's in the ER, and there are hard choices. And I think they're made minute by minute based on the best they can do. I think there's a lot of new information coming out that maybe ventilation isn't always the optimal thing. So I think we're finding other treatment modalities. But I don't think there's a singular good answer. I think the world would love to hear this is how we do it and it's fixed. Unfortunately, there are too many variables, too many different hospitals. Everybody's situation is unique. I have family and friends in Illinois. I live in Texas. I'm connected with different communities. And based on their population, who they see, their resources, how they, how they're set up, whether it's a major inner city medical center or a rural hospital, the decisions are going to be made differently. But at the end of the day, it's going to be between, the family and the provider. And then if the provider has to make a hard choice between two people and one resource, what I'm seeing right now is they're doing some unique things like using one ventilator for two patients, right? So they're changing some of the settings. They're coming up with, and this is here's kind of what I've been told, but some tactics that might be used out in the military. When you're out in the middle of nowhere and you have limited resources, you do what you can with what you have. And I think that's always going to be how we do it. I wish I had a perfect answer of how they make the decisions, but it's always the people in the room, the patients, the family, and the situation, and everyone does the best they can.
Yeah, I know that we're learning day by day. In fact, we've had Dr. Bob Arnott on this and Dr. Shulkin as well. But on the radio last week with Dr. Bob Arnott, he said we're just now learning about the ventilators and how some of the ventilators are giving too much pressure, to patients, and actually is exploding their lungs, to be graphic.
Yeah, I heard that too.
And it's actually we need to be backing off. Maybe even ventilators aren't the thing to be using, right? Or they need to be used, but maybe not in that way. Lindsay, I know you've got, critically ill patients that you take care of. How do you go through this with your patients? How do you make decisions, or you're not making, or help the family step through decisions of who should, I'm not going to say it the right way, who should hang on and who should not hang on, right, from that as well? I mean, is that even a proper thing to even ask?
Well, I don't, for our patient population, and depending on who we have, let's say like we're the fiduciary over certain patients, and if it came down to it and we were the decision makers, that we would make that decision as, I think it was Patricia was saying that we don't make that in a vacuum. The caregivers and everybody have a conversation with the healthcare providers and the family. I think for right now, what the most difficult part for our advocates and our nurses have been is when to really make the call that our patients have to go to the emergency room. So many of our patients, they're all homebound, but if an emergency comes up, if they're struggling with breathing, whatever the case is, I will be honest with you, our nurses are really thinking twice of, is this really that bad? Do they need to go, because of the fear of exposure of COVID in the hospitals? So that's been a difficult decision, but I have to give huge credit to our hospitals that we've been working with. We're on the line with nurses and the doctors right away. There's hotlines we can call into. And so we just have different protocols in place, but it doesn't help the patient's anxiety. And that's been something else we've been struggling with, is where we have had patients that want to use the emergency room for everything. They're scared, they're not feeling well, maybe they're on hospice, whatever the case is, and they would normally run to the emergency room. Now we're having to fight with the family members and explain how bad this COVID is, how quickly not only will your member get it, but you will get it as well. And so I think, to answer your question, I'm sorry if it's a roundabout answer, we make the tough decisions more or less of, does this warrant going to the emergency room, and is it worth the risk of getting COVID? That's been a tough decision for us.
Right. Yeah.
I think, just to jump in a little bit there as well, noticing how many of my clients and folks that they refer on to me, I have had now a couple of people come down with symptoms, and what I'm noticing is that I'm doing a lot more, not even sure what to call it, but supportive care would probably be as close as I could get, where I may be the only point of contact that person has every single day. And I feel like I'm doing much more of what would have been traditionally nursing care. Because every morning I'm checking in with them every day, every afternoon or every evening before I put my headset away. I'm talking with them. I'm talking with them about their symptoms, what they're able to do for themselves, what they might, when they might need direction to go to the hospital. It's an interesting phenomenon, because so many folks normally, when they become very ill, would just go to the hospital. And yet now, I mean, we're being redirected. Hospitals have, telehealth services where we are able to talk with a doctor or a nurse on the screen. And there are quite a few people who are being directed not to come in, and who might even be, say, yep, those are the symptoms, but until they get so that you can't breathe, please don't come to the hospital.
Well, can I ask you a question on that then, actually, because you can help me with some recommendations, and maybe this will help, but it's one thing for us to know our patients' intimate clinical history. We're intimate with it. We see it every day. We understand their behaviors. One of my nurses, and even our medical director, said today is, we're struggling in dealing with the families in a whole new way. So to your point of, I just don't know if this is the right idea for you to go to the hospital, Mr. Smith, but yet their wife could be saying, he's going, whether I have to drag him in on my back. How would you approach these families in mitigating that tension and that frustration and anger, because they can't just go?
Yeah, I mean, I suppose this really is my bailiwick. This is something that I do a lot of now, which is that I'm having mom jump on the call with us. I'm having partners share the screen, and I'm trying my best to answer their questions and their concerns about what's happening. If there's something that they know is really, really different than what is normal for Mr. Smith, I'm asking questions, maybe even more extensive questions than the nurse or doctor has asked, on the telehealth call. because that person has a lot more information than just one quick 15-minute or 5-minute screening call. And I try to encourage them to follow their body. Only they know when there is something so deeply wrong that they have to respond to it with more emergent medical care. And, families have to be heard. They're right there. They're as afraid, maybe not so much for themselves, but they're really afraid for their loved ones. And, I have families that have been immunocompromised by something that's overarching for all of them. And, they're sheltering in saying, oh my God, but if one of us has to go get groceries, what about the rest of us? How do we manage? And how do we use the protocol to keep us all safe? And what happens if one of us gets sick? And so these are, I would say, very, now normal conversations for me to have in my daily routine with clients and with friends of clients and with colleagues and friends of colleagues. And
well, I think we'll do that. I think we'll end up bringing some of their family members with us to the appointments. I think that would be good for our community day check-ins. We do 4 check-ins with our patients a day on Zoom, and then for those that we go to their homes. But I like that idea. Thank you very much.
Absolutely.
I was going to ask, are expectations being set properly right now, right, from this perspective? I think one of the things that we wanted to get into is talk about telehealth and teleservices and telebehavioral, telepsych. As part of this is services and its adoption and how it's being used. And that's part of the new normal that's out there as well. But Patricia, I don't mean to just bring this over to you, but there was an incident, I think, last week where a woman died, where she took a telehealth call. She was on a telehealth call, and she took the advice of the physician on the telehealth call, didn't go to the emergency room, because we're trying to keep people out of the emergency room. And the next morning she woke up and she was deceased, right, from that as well. And maybe that's not the complete story, but that's the gist of the story that occurred out there. The person that was on the telehealth call didn't have the right protocols, was trying to keep people out of the emergency room, was trying to go by probably outdated protocols as well, because we're learning day by day. I mean, I have a sister-in-law now that actually, has been diagnosed. She's probably on this call as well. Showed no symptoms whatsoever, right, from this, and was except for one symptom, which was loss of taste and smell, right, from that, and was diagnosed with it. And with that, we don't know how many other people are out there that are asymptomatic, right, that should be tested, right, from that standpoint, and are not receiving testing, right, as well. So, part of my question on this is, how can we use telehealth responsibly, right, to try to help with the behavioral health side of this, but also trying to take the pressure off of the emergency room as well, right? Long question, but Patricia.
That's okay. I'm going to break it into 2 kind of answers. So one question is about extending our reach as providers so we have more information. And it's unfortunate that this situation didn't work out, but I don't have the data, but I would assume that the ability to reach out into people's homes and get more information about patients and where they're at is a helpful thing. When we look at healthcare in general, it's not a perfect science. Sometimes you do all the right things and you still have a negative outcome. I can tell you from my years in the ER, some people should have died and I don't know why they didn't, and other people should have lived and I don't know why they died. There's that component that's just the reality of medical care. So I think telehealth is a super extension of gathering of information. You can see them, you can see skin, you can see their breathing. There's a lot of additional clinical information that can help a provider in making those decisions. And to your point, guidelines are evolving. In the last 3 weeks, I've heard, like you said, ventilators, and now it's like, well, maybe ventilators are over ventilating. Now we're talking about proning people and positioning, and just, it's gonna evolve. Getting to the mental health side of it though, I think there has to be, and again, an acknowledgement that we have changed. And so as people are grappling for the right answer, we won't always have one, but I think what people need to be specific about doing is pausing. you have two different ways to sort of to react to a situation. And one is frantic and, oh my gosh, what do we do? And the other one is to step back just a minute and assess the situation and consider many different things. Because as you consider the different options, as you get into a more proactive than a reactive approach, you're going to have different information from which to make your decision. That can apply to healthcare workers. It can apply to people, to families. We all want to rush to do something. And sometimes doing something quickly is not always the best answer, right? Sometimes assessing things, getting some more information, understanding what's going on can really be helpful to getting to the best decision. So you're never going to have a perfect decision. You always, in healthcare, you do the best, right? With the information I have, what's the next best thing I could do? So how do I give you an example of that? So right now, we're doing what we're doing. We're having this conversation. We're sharing information.
Oh, she's froze for a second. Well, one of the questions I wanted to ask when she comes back on this.
I'm back.
Oh, there you go.
My goodness.
So we're sharing.
Killing me.
Good.
I'm so sorry.
Good.
But I'll finish that thought. So if you had a call and your house was on fire, you would get off this call and you'd go do something else because you have new information. And so anything that you're doing in healthcare is based on the best information that you can gather at the moment with all the resources you have to do the next best thing. And that will just continue to happen as more information becomes available and we understand standards and all that better.
So,
I answered your long question with another long response.
But I want to ask a question real quickly, and I would involve, Dr. Breslin and Lindsay as well in this. It was about setting people's expectations, right? I think that's where a lot of anxiety comes from. I think there's a quote out there that says when people are thirsty, they'll drink sand just because they don't know better, right? From that standpoint. And we're being fed a lot of information here in Arizona. We've had a gentleman die from going out and taking hydrochloroquine or whatever it is, right? But phosphate, right? From the wrong thing. They saw it, that hydrochloroquine was actually something that would keep them away from the virus. And they went out and found it in their fish tank and they took it and put the wife in the hospital and the husband passed away from that as well. We're also setting expectations that we may all be back to work by May 1st, right, as well, potentially. We're certainly not having that expectation in our family or in our company. But part of the thing that, I'm just really worried about from the psyche of all this is being honest with people and as much as we know and communicating as much as we know. So Dr. Breslin, how is that affecting, people within your practice and people you deal with, right, as well?
Yeah, it's interesting. I think that first and second week of sheltering in, that was the conversation. What is our new normal? How long is this going to last? Give me some certainty in an uncertain world. How do I find that? Who do I talk to? I think people quickly learned that the news was probably not the place to get any sense of certainty because so much information was coming through that, let's say just wasn't always the same information, a lot of misinformation. So I would say, now we're looking at trying to help our clients and colleagues just do the best they can without any further information about when. So I often say to clients, all right, if this were going to be how you are, and you have no idea how long this is going to last, how do you create the best possible situation for yourself? What do you need to change? What do you need to morph? How do you need to fine tune this thing so that it's manageable, so that it's doable? Some people have found, all right, I think I would probably, shop twice a month, or I now am going to put myself on a little bit more of a schedule with sleeping, or now I've discovered that this helps, or daily walks help. So it's really helping people say, okay, what is the downside for being over-prepared?
Right. So Lindsay, really quickly, what's the thing with toilet paper, right? No, and that's a psychological question. What's the thing with it? What's
So
happening?
no, I have the absolute best response to that. So we have our patient population demographic varies from 0 all the way up to 90.
Yeah.
And one of our patients said, oh, the nurse is coming over today. She came over and their children had gone out to Costco and bought them 25 bundles of toilet paper that were lining up against the wall.
Awesome.
Yeah. So that was funny. That was a good thing to see. But yeah, they're hoarding. I think one of the things, if I can ask a question to you and Patricia, you brought up the behavioral health piece in telemedicine. We all know, especially I can only speak to Arizona right now, that our behavioral health funding is really low here. If we're moving to a more telemedicine-based environment, when do you think behavioral health and their funding would be able to catch up and actually implement some kind of telemedicine? Because I'm not seeing a lot of behavioral support from the telemedicine perspective right now.
So Patricia, do you want to answer that first? I mean, we did have a webinar a little bit on that last week. Go ahead.
So I did watch that webinar. It was fascinating, by the way. So I can't speak to funding. It's not my area of expertise, but I can tell you as, an individual practitioner, it's a way for me to extend and meet people. So, I coach people with diabetes burnout, people who are stuck at home. And kind of like you said, Dr. Breslin, where it's like, this isn't going away. I'm having this forever, and how do you mentally wrap your brain around it's never going to be the way it was? Those conversations and that coaching support can be done over the phone, right? I don't need to see someone. It's not a physical assessment. So I can actually connect with them that way. And again, I have an individual practice. I'm not in the guise of a hospital or anything like that. But I do think we're in a brave new world and things will never go back to the way they were. Just listening to the webinar last week, the panel really talked about now this infrastructure is quickly being put in place. It may not be there yet, and I don't know the dates, but once all this is here, it's not going to go away. So I think we've forever changed. Again, this so likens to 9/11, where everything that we had to do to overcome 9/11 is still happening today. If you look at airports, things like that. So I think telehealth, and I add this too, I don't think this virus, once we are no longer stuck at home, we still go outside and I don't have immunity. I have type 1. I'm one of the people who could, I'm high risk. So this is not a short-term thing. I think to Dr. Breslin's point, this is a long-term thing. And so infrastructure may not be that there right now, but it's happening. And I kind of see telehealth in 3 different ways. So there's always the provider to patient, right? It's a direct line where you're calling, talking, doing something together. As we mentioned earlier, I think it's a great opportunity in behavioral health to have groups. And so you learn from other people. In my diabetes world, there's such great comfort and connection to know you're suffering like somebody else is suffering. You're not alone. Somebody else shares that. And the third way, and so this is something I've done, but I have an e-course. So it's almost on demand. And again, this is not intimate one-on-one digging into your stuff, but it is a great way to help people work through things, provide information, guidance, and direction, and it's on demand, right? So it's not YouTube, it's a course, but I think people were already doing that, right? People were already finding information online. So if we can give them much more structured and specific content. But again, I think it's not going away. It's going to be here and it's only going to get better. I know CPT codes are coming out. There's just a lot of legislation around getting reimbursed for these services. And once that's there, it won't go away.
Yeah, I think that's going to be a humongous support because a lot of these patients are going to be in their homes for a very long time. And so I think that that's the next logical step for a lot of these folks. So I appreciate your insight on that.
But it's interesting. I'm actually finding myself from a psychological point of view, because I haven't been in the office probably for about 3 weeks or so. I go there once in a while. I'll cheat. But I get up in the morning and I do my normal routine. I shave, I shower, I put on my dress clothes, right? I even put on my dress shoes, even though I'm going to be, at home here, because it's a cycle. I have my breakfast as normal. It's my psychological routine that I want to put together and stay in that routine, right, to do that. The other thing when I think about this too, is that we're all kind of reinventing our businesses too. right? So, as we're doing stuff, I mean, this is a good example of bringing experts together on, a webinar, which I've never really done before, but, now everybody wants to jump on a Zoom call and do that. How do you interact with your clients? How do you interact with your patients? Is now the new normal that we're kind of creating that new revenue stream that's going to come out of this. The new economy that comes out to bolster that's the double whammy, right? We're doing a financial hit at the same time that we're doing a healthcare hit, right? And it's really taking a toll on people, especially people that were living on the edge. And now they don't have enough money socked away to be able to take a financial hit. I mean, if they got cancer, God forbid, right? Or, COVID, God forbid, they're busted, right, from that as well. So the only other thing they can take solace in is everybody else is busted too, right, potentially. Because everybody else potentially, or a large potential, can't pay their rent, right, or can't go to the office, right, or can't afford their meals and stuff like that. So it's something financially the country had to step in to try to solve, right, from that perspective.
Well,
So,
Kent, you made a good point about what they're losing. So many of our patients have been furloughed or laid off, and now they're on COBRA without the income to pay for COBRA.
yeah.
You
So
know, and
what do we do with the homeless population, right? That's one of the things that I really worry about. What are we doing for the people that really can't speak for themselves, right, that are out there? I know, Lindsay, you do a lot of that, but Dr. Breslin, what do we do with the homeless population? That seems to have been getting worse, especially in Seattle, Portland, San Francisco, other places that are kind of out there. When I visited, I'm seeing rows and rows of tents, right, that are along the highway. And now with COVID, it's got to be even worse, right, from that. What are we going to do about that?
Well, that's a really great question. I know that what I've been hearing from here locally is taking over things like state parking lots and state park camping facilities, so that they can do like personal pup tents, so that they can utilize the space to create a little bit more ease in terms of keeping people separate from one another. Because, what we saw in San Francisco, if you have a homeless shelter and, you've got everybody sleeping, bunked up together, the next thing you know, one person has it, you get 70 people with it.
Right.
And that just it's unworkable. So I'd love for our government to begin to be more creative about looking at what kinds of resources can we utilize to better protect our homeless population, at the same time as, managing better so that they are not increasing the number of cases.
Yeah, it's interesting. You just used a phrase, but I don't think you used it that way. It's the R naught value, right? That that's
yes.
We had Bob Arnott on. It doesn't have anything to do with Bob Arnott, right? From that, but the R naught value of how many people that you potentially can infect, right? To do that. And I'll go out. I was on the radio show last week, and I'll go say, the only thing I do in the morning is I put my mask on and I go to Starbucks and I do a mobile entry, and I lube my hands with disinfectant and Purell, and they've got gloves on, and that's the only interaction with people during the day. And he said, you're cheating the system. You should be this is a highly infectious, disease. It can be transmitted very, very easily. We don't even know if it's floating in the air. And the person at the speaker right before you had it, right? And now you're breathing it in, right? From that, we don't know that yet. So from an isolation perspective, do we 100% isolate? Is there any wiggle room whatsoever, right, from this? I mean, what's your thoughts, Lindsay, on it?
That's a tough one, and that's why I was shaking my head, Kent. Total isolation, I'd love to say that everybody needs to stay home, nobody needs to go out, let's let this curve, settle itself out. But the reality is, Ken, is that people have needs to get out of the home. How do you rightfully stop somebody who is ill or not feeling well or needs something? How do we say, no, you can't leave, you have to totally isolate? I guess I'm not the right person necessarily to ask that, but for our population, we almost have to force it, and we're checking in with them multiple times a day. But I don't know how the human psyche is going to be able to take that without, to Patricia and Dr. Sage's question of, this is going to be a long road. So I think if we're going to tell somebody to fully isolate, we need to be able to give some kind of light at the end of the tunnel. And I just don't think we're there.
I'm going to give you a follow-up really quickly, because I know we're going to run short on time here. My parents are both in assisted living, right, in a rural community. Should I be safe in the fact that they're in assisted living? Because we're hearing that over 600 nursing homes in the U.S. have infections inside of them. The workers potentially are bringing it into those communities. Or are they safer on the outside of the assisted living?
That depends on the assisted living.
Yeah, that's exactly what I was going to say. I think they're saying a lot of them can be like tinder boxes, with the more newer ones, Kent, that are laid out differently. They have more areas for space. But you have a huge issue in assisted living with people that can't afford their own room. There's 2 to a room.
Yeah.
So I think it's a very personal, intimate decision that a family member would have to make as to whether or not, do I leave my family there, or is it a safer place for them to come with us? I mean, there's so many different things that play into it.
It's interesting. We just sent my parents, both remote systems that have wireless thermometers and wireless pulse oximeters and blood pressures. And my sister is like on top of it. She goes through a clinical portal and checks to see if, where the temperatures are at. But more so, in this one facility that they're at, we asked to put in like an Alexa to be able to go through and be able to talk to it through video. They don't want any video whatsoever in the facility from that, and recording video as well, which is to me a little bit odd. But my mom is pretty much on top of it. She'll say the nurse walked in today without washing their hands and didn't wear gloves as well, and didn't wear a mask, right, as well. And that is horrifying to me, right, as well. And we jump on that right away. We're on top of that. And families, I don't know if a lot of families have the ability to be on top of that. And we're looking for that kind of stuff. That's the stuff I'm kind of worried about, right?
Well, most of those residents don't have any family outside at all. I mean, so how are they monitoring that, and how are they, using their voice and speaking up? It's a tough one. I'm going to a assisted living home tomorrow to go check it out for one of our members, whether or not we're going to be removing them. So I'll definitely like to follow up with you on that.
Yeah. So I want to go through, when we went back and talked about telehealth really quickly, Patricia, from your standpoint, do you think that, the patient is okay with being on video, right? And having that video connection? Does video, when we did some video, connections a couple of years ago and dealing with dialysis patients at home, they felt like yuck. They didn't want to be on video. They didn't feel like it was, something that was, it didn't make them feel good about it. Do you think that people are used to video now as a patient, especially a chronic care patient, and want to be on video? Lindsay, you're shaking your head violently.
I have had so many of our patients say no. They're not comfortable with that. They don't feel that they're getting the same care. And I realize it's very generational.
Yeah.
I'm seeing that our more older patients over the age of like 75 are very resistant to it, even the phone, but our younger population is definitely game for it. Patricia, are you seeing any issues with that?
So I think it depends on the problem, right? So there's a level where this is bad enough, I'll talk to a doctor on a video. I'm scared enough, I don't want to go out. So I think it's a continuum, and I agree with you that age, but age and ability. So my mom would not do well. She's like your parents, Kent. She's in an assisted living. She has her iPhone and we can talk to her that way, but that's about as good as she gets. But if she was scared enough or afraid enough, she would do it. So I feel like there's this threshold that people may have. If I'm kind of that way, there's things that I would prefer not to share online or in a, and I think you have to have controls and security around it, and it's going to evolve. But I think, the way the world is moving, video is such a big part of everything, and people like to see each other. I think there's something that can be soothing about facial expression and nods, and where you connect a little bit more authentically. So, I don't think there's one answer, and I think some people are going to love it and some people won't. But I think the world is moving that way.
Well, I think
being used,
I was going to weigh in too.
Go ahead.
Yeah, what I would just want to say briefly is from my perspective, and I have specialized in trauma for over 25 years. And from my perspective, it's in how we educate our clients and colleagues and just the population at large. You know, I'm sure there are lots of people who, you know, they don't feel like getting dressed up, or they're not putting their makeup on, or they're still in their PJs. And they have to understand that when we're asking for video, it's not so that we can necessarily make eye contact or, you know, make a judgment about what they're wearing, you know, or how they look. It is truly that we need more information about the environment that they're in. I know that, you know, for me, if I provide telehealth services to somebody who's in a violent relationship and I am not on video with them, I know nothing more than what they show me, number one, and I have no idea who else is off to the side or listening in. And I could easily put somebody in jeopardy by speaking freely. So at the very least, if I have some eyes on the scene, I'm a little bit more equipped. Yeah. But there are some real hidden risks to telehealth that we as clinicians absolutely have to understand before we engage. Many of us have been using some form of telehealth services for, you know, for decades, but there are a lot of folks who are just learning how to do this and just jumping on board, and they really need to pay attention to the fact that, you know, there are hidden risks, and until you really know and understand what they are, then best to tread very cautiously.
Right, makes sense. And do you see adoption, we got to wrap up here in a minute, but do you see adoption more prevalent in the behavioral health side of it or in the chronic care side? I know, Lindsay, you made a point about reimbursement and getting reimbursed from that side, but do you see more people willing to engage from a behavioral health side of it? Dr.
Behavioral, I see a ton with behavioral health. They'd be excited about that.
Right.
My personal opinion.
Right.
Yeah.
So I'm going to finish up by just, you know, thank you in the first place, but I want each of you to kind of share your kind of parting thoughts, right? From, you know, where you think people can get, I wouldn't say a more positive attitude, but can take a positive attitude going forward, knowing that it's uncertain and how to best, you know, kind of cope with that. So, because some people may have to care for themselves and some people have to care for loved ones, right, as well, and deal with their own mortality. So Dr. Breslin, your parting thoughts on how people potentially could cope better.
Yeah, I think that finding any sort of resource, anybody that you can talk to, that you can share with, is super important. It doesn't necessarily have to be a family member. It could be, I do a women's circle via Zoom once a week, and it's so that we can hear one another, see one another. You know, there is no replacement for physical touch, but, you know, here we go. I'm right there. I'm going to hold you, right? Yeah. Being able to send a beam. I'm a firm believer in even the broad version of prayer and energy medicine. Those things can be offered remotely and experienced remotely. Right. So whatever it is that allows you to have some sense of connection would be my absolute best recommendation, whether to self, others, or something greater than yourself.
And thank you. I'll take your energy as well that's out there. Thank you for offering it. Appreciate it. Lindsay, what's your thoughts?
Yeah, I think it's about speaking up and asking for help. And for our population that doesn't like to use their voice a lot, it's something we're encouraging. It's okay. There's no, just ask for help and we joke and say, find your COVID support tribe. But everybody's out there, and I think that we just need to use our voices. So yeah, and to Dr. Breslin's point, finding support groups online, Reiki, energy healing, any form, to your point of broad prayer. I think this is a moment for us to really find out what our spirituality looks like and find our place of calmness.
Right.
Doing it by resources. So thank you.
Good thoughts. And Patricia, I don't know if you're still there or not. I know you went off the screen. Are you still there, or from that? That's why Patricia's coming back really quickly. What do you guys think is, there you are. What are your parting thoughts?
So patience with technology, right? No, I would say this so aligns with my diabetes coaching and people with burnout, because you're faced with something. We have had huge loss and permanent change. Nothing will ever be the way it was. And so in that moment, you're going to feel very uncertain. And one of the things that we can do to help us feel a little bit more stable is pay attention to the choices we do have. If we focus on what's lost, you know, oh, that's different. That's, you know, it's never going to be that way again. If that's where our mind, you know, strays to, that amps up the worry. But when it's possible to make choice about what you can do and what is true, so I can call somebody, you know, what are the things we can do? Those are very empowering, and it gets you kind of out of that stuck place. And when you believe you can do something, your mind is just in a different place and you're going to see new options. So again, I think this very much, it's a lot of the same feelings that I see with people with, you know, a chronic illness. And how do you find purpose and direction and stability when you've had a lot of loss? And choice is just something that really comes back time and time again, choosing something every day. I choose to get up, I choose to get dressed, like you said, putting in a routine, but intentional choice.
That's great. I know we didn't get to talk a lot about specifically the diabetic population, and we may have you guys back on to talk, you know, about the vulnerable population in itself and how we cope with that as well. So a lot of great insight. I want to thank you guys for being part of the panel tonight. This is my my therapy, right, that I get as I reinvent myself. So I really appreciate it, and I hope it was, I know it was very engaging for the participants that have been on the call as well. So I thank you for all of that. Just really quickly, what do you think the #1 baby name is going to be out there? Is it going to be Corona, right?
No.
No.
Okay.
I've already heard this referred to from my teenagers as a coronication.
Yeah.
So,
Oh my gosh.
Coronication.
Yeah.
Yeah.
And the babies that will be born will be called coronials, right, as well. Right?
Coronials. There you go.
Right, as well. So I want to wrap up and thank everybody for attending tonight. I wanted to take a minute and thank the distinguished guests, Dr. Sage Breslin, Patricia Daiker, and Lindsay Crawl, for your participating great insights as we try to adjust to the new normal on how we live and interact with each other, and especially how we deal with the complexity of information coming out related to COVID-19 and changing every hour. I'm sorry that we weren't able to get to all the questions tonight, but we will post the answers on life365.health website as the recording, as well as the recording from tonight's webinar. Please be safe and healthy, and we look forward to having you join us next week for the next webinar next Wednesday, April 22nd at 7 p.m. Eastern Daylight Time, with the adoption and utilization of telehealth services or teleservices with COVID-19. And we'll have Gary Wald, the founder of Teladoc, on. So thank you for participating, and have a healthy and safe evening. Thanks, guys.
Thanks,
Thank
Kent.
you.
Thank you so much. Bye.
Bye.